Hello, everyone, and welcome to this edition of the LHSN 2018 webinar series on antimicrobial stewardship. My name is Mary Helen Ribeiro Pombo, and as a fellow at the Center for Health Policy at Imperial College London, I lead on the Leading Health Systems Network program. The LHSN is a collaborative network of healthcare leaders and organizations working to improve health service delivery, based at Imperial College and in partnership with the World Innovation Summit for Health. For today's webinar, titled Nurses' Participation in the Optimal Management of Antimicrobials, we welcome your insight and comments during the presentation on Twitter by using our hashtag for this event, hashtag LHSN webinar, along with those featured on the presentation. Now joining us today is our esteemed speaker, Enrique Castro-Sánchez, who I'll briefly introduce. As a Wellcome Trust Faculty Postdoctoral Fellow and Lead Research Nurse at the NIHR Health Protection Research Unit at Imperial College London, Enrique examines social determinants of antimicrobial resistance and innovations in behavioral change, technology, and patient safety. Prior, Enrique was awarded a PhD cum laude in nursing at the University of Alicante. He also obtained a master's in public health from the London School of Hygiene and Tropical Medicine. Beyond that, he has a broad range of clinical experiences in tropical and infectious diseases, which led him to serve as a consultant for the WHO. Enrique was elected as emerging leader by the International Society for Infectious Diseases. Today, our speaker will be discussing the role of nurses in infection prevention and control, as well as antimicrobial stewardship. In doing so, he'll explore various international case studies while highlighting new and innovative examples of nurse participation at managing complex antibiotic regimens. In light of LHSN's mission to improve health service delivery, our speaker will leave us with a few recommendations for policy and practice improvements. Without further ado, Enrique, I'll turn this over to you.
Thank you ever so much for the opportunity, Mary, and the introduction. Over the next few minutes, really, I just would like to give you some ideas and reflections about this emerging field of participation of nurses in antimicrobial stewardship programs, in interventions about appropriate use of antibiotics. And I think it's really important that we try to resolve this dilemma that is presented when we think about resolving AMR challenges. So on the one hand, key documents such as the Review on Antimicrobial Resistance tell us that the government, healthcare system leaders, and private actors should expand funding and opportunities to increase the essential health workers on the front line of fighting resistance. And that makes sense. That calls for a greater number of people to be developed, to be created in the fight against antimicrobial resistance. But on the other hand, we know that we will be just under 13 million healthcare workers short by 2035, according to estimates by WHO. So we have to really resolve that challenge of thinking about including more people, developing more professional workers in the fight against AMR. And on the other hand, facing the reality that we simply haven't got enough, and we will not have enough healthcare workers. But it may be that what we have to do before asking for an increased number of resources is to consider how well we are using existing resources. And I think it's very interesting to think about the ratio of nurses and midwives related to physicians around the world. And I think that this WHO graph is very telling. In this map, you can see that the darker the country, the more nurses and midwives that exist in relation to physicians. And it is not surprising that in countries and in continents such as Africa and Latin America, we have got many more nurses compared with the number of physicians. And just to give you an example of that ratio, in the UK, we have got just about 150,000 practicing doctors, whereas we have got just under 400,000 nurses. Moving on to the US, there are just under 4 million professionally active nurses. And in a country as India, a continent as India, we have got just under 1.5 million professionally active nurses. So imagine if you were to engage just an extra 1% of that workforce in antimicrobial resistance and antimicrobial stewardship activities. Just think about what it could do to your service, your ward, your clinic, and your healthcare system. And I think that is also very interesting to consider how more modern views about who should be involved in antimicrobial stewardship efforts suggest that from the typical core of an infectious disease physician and a microbiologist and a clinical pharmacist with expertise in infection, which I don't think anyone will argue that are essential, more modern views, as I say, suggest that other members, such as specialist nurses and infection prevention and control nurses, could be and perhaps should be included, considering that antimicrobial stewardship efforts are really interprofessional and should be applied across the continuum of care. And that's a position which has been around already for a few years and really put forward by Dilip Nathwani and others. But such engagement really needs to be allowed. And we know that some colleagues have already pointed out how the omission, the lack of nurses from decision-making processes related to antimicrobial therapy have really limited the extent to which nurses may influence outcomes. And that makes sense, doesn't it? When we don't include a particular professional cadre in the whole process of not just prescribing antibiotics, but thinking about how they should be used and they should be managed. And clearly their impact, the impact of that professional cadre is much limited. And looking at some of the examples that have already been published about the potential for nurses to be part of antimicrobial stewardship efforts, it's very interesting to see how it seems that the core of those efforts seem to be focused on clinical roles and tasks. And this is a very crucial paper from the US where it highlights all the different roles that nurses can play related to antimicrobial stewardship models and actions. And for example, there we can see how nurses can take an accurate allergy history, a really timely and relevant idea considering papers about the importance of ensuring that penicillin allergy is correct, how nurses are crucial to make sure that early and appropriate cultures are taken and there is a timely antibiotic initiation, how nurses are as well key making sure that those microbiological results are sent and communicated to decision makers, how any changes in the patient condition are also taken into account and considered within multidisciplinary rounds, and so on and so forth. So all these roles are crucial, are key, are important, but they seem to be focusing merely on clinical roles and tasks, and perhaps there is an opportunity to consider other areas and other spheres of practice. More recent qualitative papers kind of reinforce the views that nurses have got a place in antimicrobial stewardship interventions and programs, but that such place is probably limited to, again, clinical roles and tasks. And this paper reports the points of view from nurses about what they should be doing. So again, there is an emerging evidence that nurses think about being part of antimicrobial stewardship efforts, but it may be that at the moment they are just thinking about clinical roles and tasks. But I don't think that that's all that nurses have got to offer related to antimicrobial stewardship efforts. And already some more authors have highlighted how it is important to consider the input on educational programs, for example, making sure that undergraduate, postgraduate, and continuous professional education take into account antimicrobial stewardship and antibiotic efforts, and how it is essential that research efforts also consider what the prescribing patterns may be, for example, among nurse practitioners, and the impact of different infection prevention and control professionals on antibiotic stewardship efforts. So I think that this is another crucial paper that highlights how the scope of practice of nurses in areas related to antimicrobial use can grow, and it will be important to reflect upon how we can make these areas grow. And touching upon the prescribing aspect, which seems may not be that relevant to every setting around the world, it's important to think about that if we take into account that about 80% of antimicrobials are prescribing primary care, and an example in Scotland, just under 6% of all antibiotics in that setting are prescribed by nurses. It may not be that far away before community nurses, certainly in Scotland, but around the world as well, may be prescribing more antibiotics than hospital doctors if current efforts to ensure that prescribing in hospitals is improved. And again, we have got a recent paper by Courtney and others in BMJ Open, really graphically demonstrating the increase in the volume of antimicrobials prescribed by nurses in the community. You can see that growing trend, and I'm sure that there are similar efforts and similar data and results around the world. And again, if you think about the connections and the relations that some of your infection prevention and control nurses will have with many other relevant programs that could have an impact on antimicrobial prescribing and infections, you can see how already nurses may play a central role in efforts about appropriate use of antibiotics. So in this example, you can see how the infection prevention and control nurse in any setting really will have good links with vertical programs such as tuberculosis and HIV, vertical programs such as hepatitis C and B, community engagement efforts and communication about any outbreaks or emerging infectious diseases, certainly strong links with policy development, guidelines committees, and patient safety. Certainly there will be some connection and some joint efforts with the antimicrobial stewardship committees and staff. And depending on the setting, there will be clearly an impact on water, sanitation, and so on. So again, if you're thinking about how to incorporate nurses onto your antimicrobial stewardship efforts, you already have got probably most likely really strong links with many other relevant professionals, many other relevant teams. So you're not really starting from scratch, starting from zero. Again, widening the scope and leaning on some of the more public health focused statements that have been put out there, for example, by the Royal College of Nursing in the UK. You know, the Royal College suggests that nurses can reduce the demand for antibiotics by really influencing public and patient knowledge and expectations, and leading and implementing immunization programs, another really important, emerging and relevant area where we know that immunization can have an impact on infections and therefore can have an impact on antimicrobial exposure. And finally, you know, nurses can really lead public health strategies that support citizens to live well and really reduce the need of antimicrobial use. For example, making sure that people living with long-term conditions do not develop infections or acquire infections. So again, you know, moving away from the kind of clinical roles and tasks, bedside-oriented jobs, and thinking about the wider picture, the wider determinants, and the more public health aspect of nurse participation. There is already very powerful evidence about the impact that nurse-focused antimicrobial stewardship interventions can have, reducing antimicrobial usage. And this paper from a few years ago, very interested about the impact that an educational program can have on the usage of antimicrobials. So when nurses were exposed to dedicated education intervention, there were improvements in the volume of antimicrobial use on a center into residential aged care facilities, long-term care facilities. And again, other education-based interventions suggest that when nurses are offered the opportunity to learn in depth about the use of antimicrobials and associated tasks, then there are improvements along the line in the use of IV antibiotics and the management of IV lines and the likelihood of nurses feeling confident and empowered to discuss prescriptions of antibiotics. So again, it's important to think about not just the technical knowledge, but the impact that these education interventions can have on other soft skills, such as communication and assertiveness and negotiation. A really, really key paper reporting on an activity where nurses were giving a script, like a tailored intervention, telling them what to say and how to respond and how to interact with prescribers related to the use of antimicrobials. So often it is thought that nurses can challenge the use of inappropriate antimicrobials, and these are research that highlights how that may be possible, but it requires supportive mechanisms such as literally telling nurses what to say to prescribers and how to engage in that debate. And we can see the marked reduction in antibiotic usage and the marked improvement in the number of interactions where nurses discuss antibiotics on ward rounds. So again, if you're thinking about implementing any antimicrobial stewardship interventions, then it is essential that you consider how to support everybody who is going to be part of that decision process. And this is truly a key paper that will have much impact and implications on services around the world, in my opinion. From South Africa, we have got this, in my opinion, wonderful example of the improvement in compliance with the duration of therapy that can happen in critical care nurses following the implementation of an antimicrobial stewardship program. So one of the very early experiences telling us that improvements and quality improvement initiatives, of course, they can take place in low and middle income settings. And when they're focused on nurses, they can be the marked improvements that we see here. So improvements from 20% compliance with duration of therapy to up to 100%, but most likely around 60 to 70% in compliance with duration. So still a fantastic impact of a fairly achievable intervention. Really looking forward to the publication of this thesis, MSc thesis, to be published. And as we have just seen some interventions that have taken place in low middle income countries in Africa and South Africa, I think we really need to ask whether there is time for nurses to be much more engaged in AMS interventions, and whether we can probably learn from the successes that we have seen in again, South Africa and other low middle income countries, using the vertical programs, using task shifting, and using new role development. So can we learn about what has taken place in those settings to try to design and model nurse-focused interventions in AMS? And I think that already there are really wonderful opportunities to learn from what's going on there. So, for example, I encourage everybody to have a look at One Family Health in Rwanda. It's an excellent franchise model that, although it focuses primarily on improving access to quality basic care and preventative services, really does it by empowering nurses to be entrepreneurs and being the owners of health posts across the country. And when I had the opportunity to visit many of these health posts, I realized how these nurses were delivering excellent clinical care including antibiotics, and using decision support and mobile phone-based frameworks. But to me, the most interesting aspect was that nurses were able to deliver care and antibiotic-related care that it was of similar quality to other practitioners, using fairly strict algorithms and fairly strict guidelines. But I think that the key will not just be to focus on the fact that care can be delivered at similar quality to other professionals, but the fact that these healthcare workers in their community were not just clinicians, but also health promoters, managers, and entrepreneurs. So I think that the One Family Health model, as a blueprint for interventions related to antibiotics, is crucial. And again, very close to Rwanda in South Africa, I was very fortunate to see how the PAC, the practical approach to care kit, that's really guiding primary health care delivered by nurses, could be a fantastic baseline where to embed antimicrobial stewardship interventions. And for example, it will not be difficult at all to incorporate appropriate use of antibiotics on existing guidelines and existing frameworks. So again, very interesting to see the number of initiatives that are taking place already, and how easy, with a little bit of sort of systems design and systems thinking, it will be to incorporate appropriate use of antibiotics on those interventions. But now, before we manage to do all that, it may be that we really need to consider the barriers that still have to be resolved. And I kind of thought about these 4 barriers: foundational, branding, educational, and leadership. And it's very interesting to see how some of the evidence already suggests that in order to integrate nurses in antimicrobial stewardship, we have to resolve given barriers about education and practice and the culture of the healthcare organization. What do I mean by foundational? So if we were to ask, do nurses think they should do antimicrobial stewardship? Probably the answer is that not really. And we know that from one of many pieces of evidence in this study, where different professional groups were asked about their attitudes towards antimicrobial stewardship, nurses were the least likely to have heard about antimicrobial stewardship and the least likely to be willing to participate in AMS and antimicrobial stewardship interventions, just under the willingness shown by other professionals as surgeons, but really, really far away from physicians and certainly from pharmacists. So it looks like nurses don't think they should do AMS. Now, it may be that perception is related to an issue of lack of ownership, perhaps a branding issue about antimicrobial stewardship. Because when we look at the evidence that has just been published from, in this particular case, the study across Africa, asking nurses, specifically nurse managers, about education and management of antimicrobials, it's very interesting to see how an important number of actions that we will consider to be antimicrobial stewardship, or actions that are included in antimicrobial stewardship efforts, are really carried out by nurses across Africa. So starting from the top, just over 10% of nurses prescribe antimicrobials, but moving quickly, more than 30% of them collect quality specimens for microscopy. Just under 40% of nurses ensure that adequate doses are given. Just over 40% of nurses are members of the committees making decisions about antimicrobial prescribing, and just over 50% of them lead or take part in audits and data collection on antimicrobial usage. So again, it's very interesting to think about when we ask nurses whether they do antimicrobial stewardship, most of them say no. But when we look at what they actually do, many of the actions that are included in antimicrobial stewardship interventions are routinely carried out by nurses. And this is data from Africa, but I'm sure that is exactly the same in your settings and settings around the world. And again, if one thinks about 2 of the actions that seem to be most likely to be attributed to nurses, so reminding or challenging prescribers about the need to review current regimes or likely inappropriate regimes. It is there, it's taking place, but it's actually not one of the tasks that is most frequently carried out. So again, much of the, in my opinion, conflict that may arise in organizations when suggesting that nurses need to be part of antimicrobial stewardship efforts focuses on the tension that is perceived by nurses about the need to remind and challenge prescribers. But I think that we can resolve that issue by taking into account many of the other interventions and actions that nurses can carry out before having to challenge or remind anybody, or in addition to reminding or challenging anybody. And again, if you think about the core activities that we consider to be appropriate use of antimicrobials, and this is taken from Start, Smart, and Focus, sort of the template for AMS interventions in the UK, you can see that many of these interventions are actually what we could call not AMS, but this is really essential care, essential management, essential nursing care, if you want to put it that way, if you want to frame the message in such a way. So, imagine if you were able to increase just again by 1% the performance of your teams and your organizations in all these different areas in the adoption of appropriate infection prevention and control measures, on how well biological samples are obtained, how patients who are able to now take oral treatments can stop IV treatments. So again, it may be that where we need to focus the effort is not on the label of antimicrobial stewardship, but on framing the narrative that it's appropriate to all the different professional groups. And I think that this paper from Grayson in Australia was absolutely excellent in suggesting how the different messages related to antimicrobial stewardship could be tailored to the professional groups. So, for example, it may be that nurses really need to be told that whilst antimicrobial prescribing may be someone else's responsibility, providing excellent care for patients is nurses' responsibility. So moving away from the technical task of prescribing to the technical task of providing excellent care. And again, ensuring that nurses see that not just challenging, but ensuring that every single step involved in the care of a patient is of optimal quality. So I do think that we have got an opportunity to move away from the narrative of challenging and reminding others to the narrative of providing excellent, humane, person-centered care. And of course, there are opportunities to integrate and have synergies with existing structures. And in the paper that we recently published, you can see how already there are many opportunities for nurses to add on rather than to replace, which is not the idea. And of course, to add on and complement rather than to become a parallel antimicrobial stewardship team. So think about the areas that we suggested before and think about the influence that nurses can have in essential areas of care and how they can complement the responsibilities of other professional groups. In terms of education and educational barrier, if we were to ask, do nurses know what to do in AMS? Again, the answer would be not really. And sadly, we know that that lack of knowledge really stems from undergraduate education. So in this paper that we published some years ago, focus on the undergraduate curricula in the UK on all the disciplines that are part of antimicrobial decisions and antimicrobial management, anything from dentists to pharmacists to nurses to doctors and vets. We can see how when we map the key antimicrobial stewardship components that we've shown before from Start, Smart, and Focus, while some of them are kind of universally taught, nurses really don't get proportionally much undergraduate knowledge about the need to review, for example, broad spectrum antibiotics, certainly the need to consider intravenous to oral switches, And of course, you can see how there was very little education about single-dose surgical prophylaxis and how crucial that step would be. So as a result of that gap that we elicited, the newer national antimicrobial prescribing and stewardship competencies have been able to suggest how best address those gaps. And more recent studies have highlighted the competency domains that should be or could be embedded in undergraduate curriculum across all disciplines. So again, we start to build a global community of learning and community of practice. So all professionals that are involved in the management of antibiotics really have got a common language, common competencies, and common descriptors about what should be done and how to do it. And this sort of movement of increasing competencies in education and training on antimicrobial resistance really is not just focused or is not taking place at the national level, but the World Health Organization recently released a competency framework as well. So again, this movement away from knowledge towards competencies, skills, and behaviors and attitudes is taking place globally. So again, it will be really useful to see what is happening in your setting and whether these innovations are also taking place in your setting and in your country. Because I think that when nurses require or demand support, the gaps that they highlight simply reflect current gaps in the education that they receive. So what I mean is that in this recent paper, with a really powerful title about how nurses are underutilized in antimicrobial stewardship, the support that was claimed by nurses simply reflected the gaps that we've just seen. So how to interpret microbiological results was highlighted there, and how to best use IV or include IV to oral switches were also highlighted there. And but talking to a global audience, I would be remiss if I didn't think about how in my setting and in your setting, both the concept of a nurse and the concept of knowledge are not really static. So think about all the different healthcare workers and professionals that may be practicing in your setting and delivering care in your health system. So not just the traditional doctors, pharmacists, nurses, but also think about community and traditional birth attendants and doulas and auxiliary midwives. Think about how everybody who is delivering care to your patients may need to have some knowledge related to antimicrobials. And again, this paper focuses on comparing the faculties of using antibiotics independently across the world in some healthcare workers. Suggests that, for example, in Bangladesh, community traditional birth attendants were they were authorized to use antibiotics and they had the training to do so. How in India, auxiliary nurse midwives were in similar position, how in Nepal, and how in Pakistan, there were healthcare workers that they were not traditional in the sense of doctors, pharmacists, and nurses who had the faculty, authorization, and training to use antibiotics. So it's powerful to think about the new roles or roles that we are developing. And for example, in the UK, we will soon have a new role called nursing associate, where these professionals will be giving medication to patients. So what should they know about antibiotics, and how should they be part of the antimicrobial decision and usage? And I think that as a result of those gaps that we've seen, it may be that we have to develop, and some resources have been developed already to try to help. Some nurse-specific resources have been developed to help. So I encourage everybody to download these free resources, free ebook from the British Society for Antimicrobial Chemotherapy, which includes for the first time a chapter focused on the role of nurses in stewardship. I encourage everybody to think about how to develop decision support tools and algorithms that can help nurses make optimal decisions about, for example, urinalysis in this case. Because if you think about it, the output of every clinical and diagnostic test may be shaping prescribing behaviors and others. So it's very important to make sure that nurses are not unnecessarily sending, in this case, urinalysis, so prescribers don't feel the need or the urge to act upon those results that may not be optimal and therefore may be resulting in prescriptions of antimicrobials. I find fascinating that dialogue support could help, again, scripts that have been built like movie scripts, so people learn them by heart, professionals, and then when they think about the need to address suboptimal performance, they know exactly what to say. But I think, again, it's essential that we involve all professionals so they know that these scenarios, these situations, these encounters are going to be taking place. And therefore, they're not surprised when a nurse or another professional wants to discuss the performance or the management of a particular patient. So fascinating to see how this low-cost, low-impact intervention can have actually a dramatic effect on the performance, not just of single individual professionals, but of teams as well. The use of mHealth could, a nurse-focus-specific app helping improving antibiotic decisions. And in this case, this example from the Netherlands, the reporting on how to develop an app to support nurses in antimicrobial stewardship. So again, you can see the wide range of options that are available to you, including Games Health, what we call G Health, the game that we've developed here at Imperial College to try to embed optimal prescribing behaviors, not interested at all in teaching professionals about what drug to use on which bug, but to teach professionals about what behaviors may be optimal in managing patients that may or may not need antibiotics. And again, the beauty of the game is that it's not focused on a given professional group, but everybody that is part of antimicrobial decisions and management can play the game. So I encourage everybody to download and use the game. And finally, I do think that we need to resolve a leadership barrier in order to incorporate nurses into antimicrobial stewardship efforts. While some national documents have aimed really high, and in this case, this white paper from the CDC in the US and the American Nurses Association really redefines the role and participation of nurses in antimicrobial stewardship, whilst, to be fair, highlighting some of the gaps that are still around in terms of what would be an accepted metric of success to quantify the impact that nurses could have. But it's still a wonderful example of leading organizations releasing national documents. Other documents have not probably aimed high enough. And in this case, we have got the highlighted text corresponds to the content related to nurse participation in the newly released EU Commission guidelines for use of antimicrobials in adults. So, for a document that was released just a few months ago, the responsibilities and the role apportioned to nurses was modest and perhaps not as progressive as it could have been, certainly in view of the growing body of evidence related to impact that nurses could have. And the National Network of Nurses working in AMS in the UK felt so strongly about this commission document that we wrote already a letter that was published on CMI saying we would like to do more and we would like to do better about antimicrobial use. So perhaps this was a missed opportunity to serve as an example to other countries outside of the EU to demonstrate what we could do in terms of nurses. Networking opportunities certainly will help. So again, there is an emerging number of conferences and congresses and symposia that take into account the role of the clinical nurse in AMS in Africa and other settings around the world. Here at Imperial, we organized the first International Nursing Summit on Antimicrobial Stewardship, a wonderful organic opportunity to bring together everybody with an interest in appropriate use of antibiotic within nurses. And hopefully in November, we will have our second International Nursing Summit, so we will let you know. And I think that we cannot let the opportunity go of the political momentum. We are at a wonderful political time to suggest the increased participation of nurses in areas where traditionally we may have not been present. So you cannot miss the impact that the Nursing Now campaign, led by WHO and the International Council of Nurses, has had and is having. So this may be a wonderful opportunity to highlight areas where nurses could do more. And to sum up and to conclude, I think that antimicrobial stewardship programs must really consider multidisciplinary participation. Probably currently nurse participation is clinically oriented and therefore nurses may be underused. And underlying organizational determinants must be taken into account and evaluated before starting or expanding any interventions related to participation of nurses in AMS. Thank you ever so much for your attention. And if you have got any questions, just use the chat and we will read your question aloud to the group. And raise your hand and pose a live question. Thank you.
Thank you again, Enrique. It seems that optimizing the role of nurses in various areas of healthcare provision, including AMS initiatives, is certainly an important topic. As you've mentioned, nurses are too often not enabled, resourced, and supported to use their education and expertise to their full potential. So thank you again for exploring this timely topic, as it is one that the 2018 World Innovation Summit for Health will be examining in Doha, Qatar this November with the release of its Research Forum report on nursing and universal health coverage. So if you'd like to hear more about that particular forum, we invite you to follow updates on the WISH Summit webpage and social media accounts. Now I see that we have a few remaining minutes, so we like to open the session to the audience for questions. As Enrique has already outlined some of the functionalities for posing those questions, so we welcome that. Welcome questions, comments, and your reflections, along with your name and affiliation. In the meantime, to start, we have a few questions. Since Enrique, you are principally based in the UK, though we know that you're obviously knowledgeable about many other systems. We could start off by asking, how do you see the nurse's role evolving in the future within hospital-based NHS Trust AMS programs?
I think that is a wonderful question, because it may be that nurses already leading or being part of infection prevention and control teams could adopt some AMS related roles. It may be that we need to increase the capacity in terms of nurse consultants, nurses in advanced practice in AMS. And already in the UK, we have got wonderful examples of nurses in those positions that are really galvanizing AMS activities in their hospitals and communities. It may be that we need to think about whether a more horizontal model where most nurses in a given organization put in practice those key 9 components of antimicrobial stewardship interventions may be optimal. So we know that nurses need to be more involved. I don't think that we have got best evidence about which model will be most appropriate for the UK. So maybe that we have got a mixture of individual roles and increasing capacity across organizations. But I think that's where it may be that if we are being a little bit controversial, the infection prevention and control teams and antimicrobial stewardship teams come together as patient safety and quality teams, and that would be maybe a possibility. So again, we have only just started, and it may be that we need to see what the evidence tells us about that participation models.
Excellent. So we have another question here. And we have it from, and I apologize if I mispronounced this, Ingeborg Grutus. And she's posed the question of, since 4 years, I'm an antibiotic nurse and an antibiotic team in Holland. In the last 4 years, there are 12 nurses participation in 8 teams. Are you aware of this?
Hi, Ingeborg. I wasn't aware that you had 12 nurses in 8 teams in Holland, although I knew about some of you thanks to the people that have joined in the national network of antimicrobial stewardship nurses in the UK. So we have got people from Norway, Sweden, and so yeah, I knew about you guys, you people, AMS, but not about 12 in 8 teams. That is fantastic. That is amazing. I really would love to know about you all and to learn about what you do and to see what we could do over here. So thank you.
Wonderful. Thanks so much for that. So before we wrap up our session, we'd like to offer all of our speakers an opportunity to leave a few takeaway messages for the audience.
Thank you. So thank you, first of all, for the opportunity, and I hope that everybody found it as enjoyable as I did. My couple of messages will be, we do have to perhaps consider how best use all human resources that we have available in health and social care if we want to really have an impact on AMR, antimicrobial resistance. I do believe that nurses would like to be much more involved, and perhaps all that is needed is a little bit of planning and a little bit of learning from other settings in order to be able to incorporate the largest workforce in healthcare across the world.
Wonderful, thank you. I guess we do have one other question. Maybe we could squeeze it in since we have a few minutes. I'm going to unmute Denise. Just a second. Hello, Denise. Can you hear us?
Yes, I can hear you. Can you hear me?
Yes, perfectly.
Okay. Well, let me first introduce myself. I'm Denise, and I started working as an antibiotic nurse when just June the 1st last month. So it's kind of new, this whole world to me. What I've been trying to do in the hospital, because we didn't have the function or the a nurse in the hospital. So I'm the first one who does this in this hospital. And I try to figure out a little bit about how much the nurses already know, working on the different departments, how much they know about the antibiotics, and if they were open to learn about antibiotics and the resistance. And I found a lot of the nurses who said, like, we don't want to learn it because that's not our responsibility, but it's the responsibility of the doctor. And I was wondering if you have some tips how we can make the nurses a little bit more enthusiastic, to learn more about and to be more open to learn about antibiotics and take the responsibility that we have as a nurse. Do you have any tips?
Thank you so much. So first of all, can I ask you, whereabouts are you based? Which country? Which setting?
I'm in Holland.
Oh, fantastic. Okay, so
I'm a nurse from a hospital in Amsterdam.
Fantastic. So welcome to the world of antimicrobial stewardship nursing. So it is fantastic. It is really exciting. In I suggested that perhaps we have got a problem about labeling and about branding our participation in AMS. So if you were to say to the nurses that are not interested in learning about antibiotics, which I think it is a pity, how focusing on delivering excellent care to the patients, so ensuring that, you know, patients who don't need to have IV antibiotics can have oral antibiotics as appropriate. How about focusing on ensuring that cannulas are removed as soon as possible, that catheters are removed as soon as possible, that patients are well hydrated, so then there is no need to send urinalysis if people are dehydrated, which may lead on to inappropriate prescribing. How about focusing on participating in multidisciplinary ward rounds, so improvements in patients' condition can be discussed with prescribers timely or in a timely manner, and therefore patients can stop having antibiotics as soon as possible. So again, I think that we can debate about whether we should do and know more about antibiotics, or we can focus on what I call essential care, like the essential diagnostic list that WHO has just released. Why don't we think about essential care, fundamental, top quality, person-centered care that includes some elements that are relevant to antibiotics? So, you know, before getting into the big battle of should we know more about antibiotics, how about making sure that all those components that I've highlighted are performed at the best possible quality?
Yes, thank you. That's a really good tip. I also think that the nurses are complaining about getting more of a responsibility because they also have to do a lot of like the administration and stuff. So I think that's also something that I need to work on, how to make them enthusiastic without making them feel like it's more work for them. Because a lot of nurses, it's all about the patients. And I think that I am going to highlight, because I'm planning to give a presentation this year about antibiotics. And I think that's a really good tip you gave me. Thank you very much.
No problem. Thank you for your time.
Thank you again. Okay, so a special thanks goes out to you, Enrique. Thank you for joining us, and a warm thanks to our audience for joining us here today. Recordings of this webinar will be available on our website at www.leadinghealthsystemsnetwork.org. As a reminder, LHSN is on social media, so please feel free to follow us on LinkedIn, Twitter, and YouTube, where you can get access to recordings and new webinar announcements. Prior to ending our webinar session now, I'll leave you with an invitation to attend our next two webinars. On Tuesday, the 17th of July, we have Dr. Ahmad and Dr. Charani from Imperial College speaking on key elements for antimicrobial stewardship programs. And on the 18th of September, Dr. Gao, Dr. Chen, and Dr. Hyder from PharMerit International and Pfizer will provide a regionally focused webinar on adapting the U.S. AMS program guidelines to build an economic evaluation framework for Chinese hospitals. So to receive reminders about these upcoming webinars, be sure to sign up for the LHSN newsletters or individual webinars of your interest. So with that, we close our session, and we wish you a great day and hope you'll join us again on the 17th of July for our next event. Thank you. Bye-bye.
Bye.